So this is supposed to be on mute, right? This is supposed to be on mute, right?
I don't know. We can ask our tech. You can. I think you can use either one. If you like, if you want to move it around, that's a better one.
No, I thought it has to be on to tape, doesn't it?
Oh, you're right.
I was.
Actually, it doesn't. Because I
Are
can use
you?
it. I just use the mic system.
You didn't have this on, really? And it tapes it in here?
Using both echoing, so using
Yeah.
one or the other, but it's up to you.
Oh, I thought this had to be on to be taped. No?
I did. They only brought that out.
Well, that's funny. It always used to be that if this wasn't done, they didn't. If this is on mute, are they still taping, videoing? Oh, so they can get it off of that as well. Yeah. So it doesn't have to be on for that. Oh, okay. Good. So should we get started?
Good morning. We're going to get started. It's my pleasure to introduce Dr. Robert Basner to you. Dr. Basner is a professor of medicine in the Division of Pulmonary Allergy and Critical Care Medicine. He's also the director of the Cardiopulmonary Sleep and Ventilatory Disorders Center and the director of the Pulmonary Function Laboratory. He is a world-recognized expert in sleep-related breathing disorders, and you have the good fortune to hear from him about that subject today.
Can you hear from me right now? Okay. All right, so something a little bit different, so we'll get started. Anyone recognize the author of this cartoon? Just call it out. No? Nobody? Nobody. James Thurber, a famous American great comic writer, a genius, wrote a series of things about sleep disorders, basically, even though he didn't really mean it as a medical survey. And so, obviously, there's some sort of a goblin ghost coming after this man who's trying to sleep. But the key issue is here, the caption, he always half suspected that something would get him. So, nothing to disclose. So the objectives today is very. This could take a year to go through. All right. So we're only going to have 50 minutes to get a survey here. But basically, I'd like you to begin to appreciate that nobody in this room who's going to be a physician should half suspect that something is going to get patients during the night during sleep. Something is going to get patients during the night during sleep. To appreciate that sleep is a state of challenged respiratory and cardiovascular homeostasis, particularly in your patients who have challenged respiratory, cardiovascular, and metabolic disorders. We want to try to classify, define, and characterize the major sleep-related breathing disorders, although unfortunately we won't have time to go through all of them. But I also want you to appreciate that these breathing disorders during sleep are treatable if you recognize them and look for them. And I'm going to give 3 illustrative cases just to nail home the point. So I guess you've already seen these slides. There are no surprises or jokes that I can make. It used to be that I could put up an extra slide to surprise you, but then I got told that my slides were out of order and I couldn't do that. But Mark Twain said this, to stay with the literary bent, and it's a very apt quote. So let's first of all talk a little bit about what sleep is. So normal sleep, we generally break down into non-rapid eye movement and rapid eye movement sleep. And of the non-REM sleep, we divide it into stages 1, 2, and 3. 1 and 2 being a lighter stage, and 3 being a very deep stage, the kind you're all in hopefully early in the night. Then we progress into REM as we go on. And this is an example of either somebody who's encephalopathic or in slow wave sleep. These are high, big delta waves, nice regular heart rate. And so during non-REM sleep, we have dependence on metabolic control. We're basically on autopilot, and it's only the metabolic system that's driving breathing. We have a loss of voluntary and behavioral control, all the kinds of things you're doing right now that you're not even thinking about necessarily. But non-REM is permissive of respiratory periodicity, so if you're going to have periodic breathing, the time you're going to do it mostly is in light non-REM sleep. One of the lecturers, Dr. Abrams, I believe, told you that alveolar hypoventilation occurred during sleep, and that's absolutely illustrated here. The minute ventilation may decrease by as much as 1.5 liters per minute, and normally PCO2 can be in the 45 or so torr range. So we tell you that your job in life when you're awake is to keep your PCO2 at 40. I hope you learned that already in this course. You have nothing else to do but to keep your PCO2 at 40. Except when you're asleep, you can keep your PCO2 at 45. So if that doesn't tell you something about the interest in breathing and sleep, it really should. And non-REM sleep is a time of increased upper airway resistance. Okay, so a challenge here, and actually the slides are at the end of it, so we won't go over it, but what specific disorders of breathing during sleep are therefore likely to be linked with non-REM sleep? So we'll talk about that later. Now, REM sleep is a whole other state of existence, and REM sleep, I would stand here and say, is clearly the most challenging state of physiologic existence that there is. So there's awake, there's non-REM, and there's REM. And if your patients are going to get into a real lot of trouble really quickly, it's probably going to be in REM sleep. Okay, rapid eye movement sleep. Here are the rapid eye movements. Here's the twitching. You've probably seen your dog, for example, in REM sleep with the eyes roving around, the twitching, dreaming. This is the dream state. Breathing here even is a little bit irregular. The heart rate is a little bit irregular. So this is REM sleep. So in normal breathing in REM, we have decreased or absent metabolic responses, very much different than being on autopilot. So really, we're not working so much with metabolic responses anymore. In fact, not many clues are there to know how we are working for breathing in REM sleep. It's a time of very erratic breathing, erratic heart rate, erratic blood pressure responses. But what we do know is that we have either inhibition or paralysis of the postural muscles. We're basically paralyzed in REM sleep. Have you ever woken up in REM sleep, know you're awake, we're dreaming, but you're paralyzed for a few seconds? That's what's happening to you. That's what's happening to your patients who need their muscles to breathe, but they're in REM sleep, and actually many of those muscles are literally paralyzed. And that includes the upper airway muscles and all the accessory breathing muscles. There's irregular shallow breathing, and there's normally apneas, no breathing at all for 10 seconds or more. Now, of course, all of these can result in severe hypoventilation and hypoxemia, and particularly in your patients that are already facing sleep with problems breathing or cardiovascular problems, we're talking about a nightmare. Okay, so the challenge here is what specific disorders of breathing can we link to rapid eye movement sleep, and we'll talk about that more a little bit later. So let's go on to what's abnormal breathing in sleep. So here is the newest, latest, greatest international classification of sleep disorders by the American Academy of Sleep Medicine, the ranking body who defines these things, and actually that CMS picks up as guidelines for diagnosing and treating. So we talk about the central sleep apnea syndromes, obstructive sleep apnea disorders, the sleep-related hypoventilation disorders, and something else called sleep-related hypoxemia disorder. But we really want to think about these three on top, and I'm going to give you an example of each one of them. This is a fairly good, easy classification. If we get more into the central sleep apnea syndromes, here are the ones that we're really thinking about. These are the ones you will come across in your patients and that you need to start thinking about. Again, this 50 minutes today is not to learn about all these things, but to get a sense of what's going on and what's important about sleep and breathing. So there are the primary central sleep apneas, meaning we don't know why people stop breathing for 10 seconds. There's the central sleep apnea with Cheyne-Stokes breathing. This is a major, major problem, probably the most important problem we can talk about today. Due to high altitude, due to a medical disorder without Cheyne-Stokes breathing, due to a medication or substance, and I'm going to show you a slide on somebody who's taking opiates and who has central sleep apnea. There's the primary central sleep apnea of infancy, which we're not going to cover today, and there's something called treatment-emergent central sleep apnea, which is not something you'll see unless you're titrating positive airway pressure in the lab. Now, of the obstructive sleep apnea syndromes, or disorders really, there's adult and pediatric, and we'll talk about adult today. This is from 2005. This is the last classification. I put it up there for you to, in your leisure, to compare this to the newer one, just to see how things change in people's minds. There's something different, but it's not all that different. But this is the 2014 classification, and just to look at these hypoventilation disorders, remember, your patients with awake hypoventilation are going to have worsened hypoventilation during sleep, even without a specific hypoventilation disorder. But there is such a syndrome called obesity hypoventilation syndrome. There's what we've been calling Ondine's curse. Now, this is not a diagnosis. You can't list this really because it's very nonspecific. It's really a mythological reference, and in fact, you don't want to diagnose someone with a curse, right? But it really is based on central alveolar hypoventilation. It could be congenital, born with it, or you can acquire it through different means. There's other central hypoventilation syndromes, including idiopathic, which means we don't know why people have it. Some of these, of course, are related to central sleep apnea. If you have central alveolar hypoventilation with not as much output as you should to the neuromuscular system, you can have one of these hypoventilation disorders and also have central sleep apnea. So there's a lot of overlap. And then due to a medication or substance and due to a medical disorder. This gets very, very grand and all-encompassing. And so, again, just to give you the fact and the feeling that sleep-related breathing disorders is about as important as you can get in medicine. And yet, courses like this are few and far between. Talks like this are few and far between. So, getting back to the breathing abnormalities in sleep, some definitions. Apnea. Generally, when I ask a pulmonary fellow what an apnea is, or what his or her definition is, I don't get a good answer. So here you are. Here's a good answer. It's a cessation of airflow for greater than or equal to 10 seconds. Now, if there's no breathing effort, it's a central apnea. If there's breathing effort for 10 seconds, but there's still no airflow, we call that an obstructive apnea. Okay? So that's the difference. So apnea means no airflow, not no breathing, because people with obstructive sleep apnea are trying to breathe very much, but just have blockage in the airway, basically. So central obstructive and mixed, meaning it starts out central and then becomes obstructed through the apnea. Hypopnea or hypopnea, we say hypopnea here, the cultured people, particularly in Canada, say hypopnea because it's hypo, meaning breathing is low but not absence. A is absent, hypo is low. And so this is airflow that's decreased but not completely gone. So an obstructive apnea would be someone who's doing the Mueller maneuver like this. No flow. An obstructive hypopnea might look like this. There's airflow. So it's not apnea, but it's decreased, it's partially obstructed. Now, hypopnea can be obstructed like that, or not obstructed, just going down and up. All right. And so this is typically with a decrease in saturation. All right, so that's enough of that. If I can talk for the rest of the time. So the types of apneas: obstructive, central, and mixed. So here's a typical obstructive apnea. This is an actual tracing that we've characterized a little better. So here's the airflow that we're measuring with a nasal pressure transducer, flat for over 10 seconds. 30 seconds is here, so this is almost a minute of apnea. Repetitive, cyclic, breathing goes down, then it comes up, 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 usually in a paradoxic fashion, the so-called Mueller maneuver, which has tremendous effects on cardiac output, for example. Okay. Pulse oximetry, and you can see this is a real tracing. It's going down to 76%, back up to 97% in a matter of 10 seconds, back down to 79% in another 10 seconds, 30 seconds. Unbelievable. Heart rate is going up and down. This is obstructive sleep apnea. These are central apneas, and again, here's the flow, but here's the chest and abdominal movement, and you can see there's waxing, waning breathing, again, a periodic breathing, but this apnea, there is no effort at the nadir of the breathing, so this is a central apnea, actually in the midst of what we would call Cheyne-Stokes breathing, which we'll get to, also associated with asphyxia. When we talk about the severity, one way we can talk about it is what you hear about as you hit the wards, which is the apnea-hypopnea index, or the AHI, so the number of those events per hour of sleep. So the more events, the more frequent is the apnea or hypopnea. That doesn't mean people are desaturating more or less, it's just one measure of severity. Okay, so first case. This is a true story of a 60-year-old man, status post hip replacement, on the floor. He has a normal awake arterial blood gas, as most patients with obstructive sleep apnea do. Poorly controlled systemic hypertension, as many patients with obstructive sleep apnea have. And all of a sudden has a ventricular fibrillation arrest at about 9:30 at night. He's successfully resuscitated. Someone sends him for a sleep study. It turned out he was given opiates for the pain, and so a diagnostic study was performed. You're supposed to guess what the diagnostic study is, but of course it's a polysomnogram and will be for the next 3 cases. And this is the polysomnogram in all its glory. This is what we look at, 8 hours of data in every patient when you send someone for a sleep study. This is all EEG. Here's the heart rate, and by the way, you can see this effect of speeding up, slowing down, speeding up, slowing down. But here's where the money is. These are apneas, no flow for many, many seconds, and the effort goes down and up and up. And then the arousal, a great sympathetic surge, severe desaturation. This is that patient who got made worse by being given opiates, not being suspected of having obstructive sleep apnea. And so basically died but was resuscitated and then was treated. So obstructive sleep apnea is an apnea-hypopnea index of greater than 5 or equal to 5 with some other correlates such as daytime sleepiness or even a cardiovascular or metabolic abnormality, or just an index of 15 or above. Okay? So that's the way it's defined. That may be good, that may not be so good, but anyway, those are present definitions. Now, if we talk about how prevalent an apnea-hypopnea index of 5 is, it's about 24% of middle-aged men and 9% of women. And we think that about 80% of such cases in the United States, not to mention the world, are currently undiagnosed. So most of the people out there with obstructive sleep apnea, we haven't diagnosed them yet. And it's been estimated that that mis- or underdiagnosis is costing the system well upwards of $3.5 billion a year in excess costs, which are accruing to the associated cardiovascular morbidities. The number one cause of fatality in obstructive sleep apnea may very well be motor vehicle accident, because people are excessively sleepy. So acutely, there's abrupt arousal, desaturation, really asphyxia, blood pressure goes up and down, decreased cardiac output, increased right and left ventricular afterload. You had cardiology, remind me? So all these things should be clear. This is a cardiovascular nightmare, this asphyxia. And at the end, there's a sympathetic surge as blood pressure goes up and cardiac output continues to fall. There's increased myocardial oxygen demand, even as, because of transmural pressures in the heart, coronary blood flow is decreasing during the obstructive apnea. And so there's an autonomic change in the vagal and sympathetic. You may recognize patients through loud snoring. The patients will have a bed partner describing that. Again, excessive daytime sleepiness, increased risk of motor vehicle accident, which each one of you are responsible for in the public health domain. So if you see somebody with excessive sleepiness, whether from sleep apnea or some other reason, you need to recognize it and do something about it. Patients can complain of poor sleep quality and even insomnia because they can't sleep and they know it. Choking, gasping, morning headache. Again, the prevalence numbers I gave you, but here are some other numbers to really open your eyes, no pun intended. If you're greater than equal to 65 years, you have about a 40% chance of having obstructive sleep apnea. People sometimes ask, if this is so common, how come we even call it an abnormality? Isn't this sort of a fact of life? It's certainly getting to be more and more a fact of life as we get older and wider. Notice I didn't say wiser. Okay. Patients with heart failure, stable, ambulatory, about 11% have this kind of obstructive sleep apnea. If you have systemic hypertension, and particularly if you have poorly controlled hypertension, and you're scratching your head, why can't I get this gentleman's blood pressure under control? He's got maybe a 50% chance of having obstructive sleep apnea that if you treat, you at least stop that acute change in the blood pressure with every one of those events that are happening, usually not 5 times an hour, but 30, 40, 50, 60 times per hour every time the patient sleeps. Patients with acute myocardial infarction, if you study them, you find a very high prevalence, I should say, of obstructive sleep apnea. If you have patients with atrial fibrillation, greater than 30% of them will have obstructive sleep apnea. These are associations. This is not clearly cause and effect. And as I stand here today in 2015, I can tell you we don't have a good handle on cause and effect. We need you to help us figure this out. On the other hand, these associations are very persuasive and very important, because if you have someone asphyxiating 60 times an hour and he's got heart failure and atrial fibrillation, you'd at least like to take away the asphyxiation and then see what happens. It would seem like a good idea. For those who are interested in cardiology in particular, look how sleep apnea and sleep-related breathing disorders have all of a sudden become a cardiologic concern, right? Okay. So, the associations I told you about: systemic hypertension, decreased left ventricular function. If you're going to have a stroke, you're likely to have it for the first time and recurrent if you have obstructive sleep apnea. If you have obstructive sleep apnea and you're going to have sudden death, you're probably going to have the sudden death nocturnally. If you have sleep apnea and you have a stroke, the first stroke, looking at it the other way, the first stroke is going to occur nocturnally or in sleep about half of the time. Incredible statistic. And of course, increased risk for all cause as well as the cardiovascular mortality. Wonder why all cause? Well, interestingly, even cancer has been found to be increased and a cause for mortality more with patients with obstructive sleep apnea, making us really think about really what are the biologic underpinnings here. And it's not a simple thing at all. So clinical suspicion in polysomnography is how you diagnose. Clinical suspicion and then polysomnography. How do you manage? Weight loss is key. If you don't lose weight and you're obese and you have obstructive sleep apnea, not only can't you treat the sleep apnea as well as should be, but also you continue to have a lot of the cardiometabolic risk, even if you treat the sleep apnea. Sleep positioning, avoid alcohol, which makes things worse, usually positive airway pressure. I put 2 question marks in front of surgery. Right now, unless you're a little person, a child with large tonsils, surgery is not really recommended as treatment for obstructive sleep apnea, particularly if you're obese. And here's a man with positive airway pressure, a little mask on his nose attached to a ventilator, basically, that blows air down, opens up the airway, continuous positive airway pressure. We titrate the pressure as necessary during a sleep study, although you can do that at home if you really need to. And while typical settings are in the range of 6 to 16, if you have a patient at the bedside who's has obstructive sleep apnea and you've recognized it, a good number to think about is 10 of CPAP. You're hardly ever going to go wrong if you put somebody on 10 centimeters of water CPAP if he's got obstructive sleep apnea. So we can decrease all these things, and we can improve daytime sleepiness, quality of life. We can increase left ventricular ejection fraction in patients with severe obstructive sleep apnea using CPAP. Improve blood pressure. What we're lacking really are good randomized controlled trials, which in fact we probably will never have because we just need too many people over too long a time to show that mortality actually goes down. Okay, so that's obstructive sleep apnea. Again, we could talk about it a lot more, but let's go on to case 2 now. But I gave you something to think about obstructive sleep apnea. This is a 54-year-old man in the prime of life, but he's got congestive heart failure with a very low ejection fraction of 20%. Now, I already told you I could ask you this question right now on your exam. What's the prevalence of obstructive sleep apnea in this patient, a priori? And the answer is, what's the number that I gave you on the slide a few minutes ago? 11%, right? So a priori, he's got more than a 10% risk of having obstructive sleep apnea, repetitive asphyxiation in his sleep, okay? But he's admitted now with acute decompensation of left heart failure. He's got a blood gas that I showed here. You're very well versed now. I won't even ask you to describe this blood gas, but I'm sure you can. So we did another diagnostic study, polysomnography, and you've seen this before. This is that picture I showed you. And so this is waxing, waning breathing. This is the flow. This is the effort. And between this waxing, waning, up and down, hyperpnea, hypopnea, hyperpnea, hypopnea, and then apnea, central apnea. Then it comes up again, goes down, comes up again, goes down. Nowhere on this tracing is there an obstructive apnea or any kind of obstruction whatsoever. This is pure central apnea, but it's a very characteristic type with that periodicity of breathing. Does anyone know what we would call this type of breathing with someone with heart failure, for example? It's named after 2 physicians. Okay, Cheyne-Stokes, but of course you knew that because you looked at the slides before and you already have them posted. So I can't fool you at all here. Now, but Joseph Cheyne, and there's a doctor before Cheyne, after Stokes was later, Cheyne was in the middle, John Hunter, who described this 50 years ago. But Cheyne, the first person who described a patient who came in with a stroke and a heart attack and had this kind of breathing. Can anyone guess what year that was first described by Joseph Cheyne in the London Journal of Physiology? Just to give you a perspective on how things are going here. Anyone take a wild guess? Say that again? 1883, that's getting there. Most people say 1950. Actually, REM sleep was first described in 1955. Okay. Joseph Cheyne described this in 1818. 1818, that's how long we've known about Cheyne-Stokes breathing, or at least Hunter Cheyne before Stokes came. So the diagnosis is central sleep apnea with Cheyne-Stokes breathing. That's the classification in the International Classification of Sleep Disorders. Okay, so Pathogenesis is really unknown, and I put this slide up for you to think about at your leisure, but surely it seems as though the progress we've made shows that the chemoreceptor is firing over time, so it's delayed and hyperactive. So there's an overabundance of reacting to the CO2, so it goes up and goes down more than usual, and so that periodicity is engendered from minute to minute. So PCO2 goes up, goes down. When it's too low, you can't breathe. Especially in sleep, you need higher PCO2 to breathe. So you have the central apnea. Then you overcompensate. CO2 goes down too low. You stop breathing again. But it's that waxing waning pattern. You could recognize it at the bedside. None of these disorders do you need a polysomnogram to at least be able to say, hey, I see my patient there. He's doing this Cheyne-Stokes breathing, or he's having obstructive sleep apnea. Okay, so asphyxia, arousal, disrupted sympathovagal balance, acute systemic and pulmonary pressure responses, increases that is, and an increase in complex ventricular arrhythmias. This is what's associated with Cheyne-Stokes breathing. Again, if somebody comes in acute heart failure, is subject to this, and yet you have to think of it and try to recognize it, diagnose it, and then treat it. So this is one of many data. Again, we don't have randomized controlled trials proving cause and effect, but this is very interesting. This is one of the largest studies, happened to be done only in men, but looking at people who had Cheyne-Stokes breathing and didn't. So the blue is those who basically did not have Cheyne-Stokes breathing with central sleep apnea. The red is those who did, basically the same ejection fraction, and you can see the hazard ratio as you get out for mortality. The median survival is 45 months when you had the Cheyne-Stokes breathing, 90 months if you didn't have the Cheyne-Stokes breathing. So remarkable difference in the risk for mortality in those with and without. Now again, what's the cause, what's the effect, we don't know. But it's very reasonable to think that asphyxiation repetitively for many hours a day is not good for your heart. And as I said, we already know that in some ways. We can make ejection fraction better if we treat the sleep apnea. Okay, so you would treat the heart failure, but interestingly, treating heart failure, we still send people out of the hospital with as much Cheyne-Stokes breathing sometime as they came in, whatever the cause for that is. Heart transplant generally works. You can give oxygen alone at least to prevent O2 decreases, but it's not the major physiologic treatment. Some of the treatments you shouldn't do, inhaled carbon dioxide, people have thought if you give carbon dioxide, you'll smooth out that periodic breathing, and in fact you will, but it's just not a good treatment. It also increases muscle loading, and so it's not a good idea. Pharmacologic, all the treatments that stimulate breathing can be too stimulant effect with the heart, basically, so it's not a good setting for using theophylline, milrinone, products like that. And then there's left ventricular assist device, which may or may not help. We need to do a lot more work about that. But positive airway pressure, so even continuous positive airway pressure, CPAP, has improved things, and I've given you some of the statistics. For one thing, again, we can increase cardiac output and ejection fraction. In one study, ejection fraction went up from 20% to 30%. Huge numbers in people with severe heart failure just by treating their Cheyne-Stokes breathing with central sleep apnea with CPAP. But this hasn't worked out as well as probably some other things, and what we've been working now with is something called serval ventilation or adapt serval ventilation, which changes pressures as it picks up on the patient's periodic breathing and tries to match it. And so here's our patient again with the Cheyne-Stokes breathing, and here he is with the serval ventilation. So this is not CPAP, which we use generally in obstructive sleep apnea. This is called serval ventilation. It's a bi-level pressure. It's not one pressure. It changes with the patient. And in fact, it tends to mirror image. If you look right over here, where the patient's breathing is up, the pressure is down. Where the patient's breathing goes down, the positive airway pressure goes up. And then notice after a couple of minutes here, this Cheyne-Stokes pattern without central apnea, by the way. It doesn't have to have central apnea to still be called Cheyne-Stokes breathing. It could be just waxing, waning without outright apnea. At some point, it just converts right to fairly regular breathing. And this has been our experience. We need a lot more work to do this, but in other words, the point is that we can recognize this. It's associated with greatly increased mortality and asphyxiation, and we can treat it. And we can treat it very, very well, very non-invasively using a mask. And it doesn't involve the usual pharmacologic treatments that everybody gets and everybody thinks of. But think about sleep apnea, think about Cheyne-Stokes breathing. One thing I didn't point out to you, although it's on the slides, this kind of breathing, Cheyne-Stokes breathing in stable heart failure, outpatient heart failure, is about 50%. So that patient who has an 11% prevalence of obstructive sleep apnea also has a 50% prevalence of Cheyne-Stokes breathing of the type that's associated with increased mortality. Tremendous numbers. So you have a patient with stable heart failure, he's got over 60% chance of having a sleep apnea syndrome that can be very, very serious. Certainly asphyxiating many, many times an hour, many, many hours, many, many days. Okay. So having said that, we'll go on to one final case. These are all true cases, very common cases. This case 3, though, is a very uncommon case. This is a 25-year-old woman, HIV positive, obese, bipolar disorder. People think maybe she even has developing multiple sclerosis because she's got some kind of a medullary plaque, and she comes in with recurrent episodes of hypercapnic respiratory failure. You know what hypercapnic respiratory failure is. I was sitting in back when you had a wonderful talk about that. Okay, so this woman keeps coming in, having to be intubated for hypercapnic respiratory failure, CO2 in the 90 range. And so finally, a blood gas, when she's awake right at this time, PaO2 is normal, her PCO2 is 48. Remember, that's elevated, right? It should be 40. Unless she's asleep, then it can be 45. But 48 awake is high, and you can see it's probably a compensated, acute, chronic hypoventilation. So somebody thought to do a sleep study, which is a great idea because somebody who's coming in with one of these awake hypoventilation syndromes, and again, go back to the slide from 2014 and 2005 and look at all the possibilities for hypoventilation, obesity hypoventilation, the idiopathic, that kind of thing, and think about that, and the overlap between central apneas and the hypoventilation syndromes. That's what somebody smart did with this woman and said, wait a minute, let me see what she does when she's asleep. Well, you know what? When she came to the lab, first thing is, what is she doing when she's awake? So it's very clear what she's doing when she's awake. Here's the flow, again, in the airway. And you can see there are periods of long apneas. When you look at the effort, you can see, this is a little bit funny here, but basically look over here, look over here. These are central apneas, no effort for many seconds, at least 10 to call it apnea. Here's the CO2 monitor, the end-tidal CO2 at the nose, and I think you can read these certainly on your slide. I'm pointing at 89 right here. That's an end-tidal CO2 at 89, theoretically about the same as in the blood, arterial blood. So we're talking about tremendously high CO2s in the setting of erratic breathing. This is not periodic breathing, right? This is not the Cheyne-Stokes breathing you're looking at. This is erratic. You hardly know where the next breath is coming from. This is awake. She goes into transitional sleep, and it gets worse. Long, long periods. Remember, here's where we said we're on autopilot. We need CO2 to breathe. We're not thinking about things. We have no voluntary control. We can't say, oh my God, I wasn't breathing. I better start breathing. No, this is long central apnea, severe desaturation. Here it is progressing in non-REM sleep. Look how erratic that breathing is. Central apneas, then panting, Central apnea is very, very erratic, not periodic, not regular, very irregular, periodic, not periodic. Some people call this ataxic breathing. And finally, in REM sleep, again, probably not worse in terms of the amount of central apneas, but here we're going down to 76% saturation. Here's 74, here's 69. Tremendously low levels of blood oxygen. And this is what that woman was doing. So the diagnosis, again, I can't fool you. You know what the diagnosis is because you've looked at the slide, I think. So we go back to James Thurber from one of the pictures, the night the bed fell. Actually, the picture I showed you was from the night the ghost got in, but this is the night the bed fell. And so we had visiting us a nervous first cousin named Briggs Beale, who believed that he was likely to cease breathing when he was asleep. This was a long time ago when James Thurber wrote this. It was feeling that if he were not awakened every hour during the night, he might die of suffocation. Do any of you get that feeling about yourselves? Again, in this situation that we just looked at, this is very pertinent. So, in fact, this disorder is classified probably, I gave you two choices because it's not clear, either essential sleep apnea due to a medical disorder without Cheyne-Stokes breathing, that sounds a little complicated, or idiopathic central alveolar hypoventilation. Remember, I warned you that the central apneas and the central hypoventilation syndromes are going to come together, basically. Sometimes this is called Undine's curse, but as I said, let's not use this. Undine was the mermaid in the Norse mythology, at least, and almost every mythology has her, who gave up her immortality for her lover to become human. Her lover jilted her. So here she is no longer immortal. She's going to have to die, and she doesn't have her boyfriend either. She cursed him, and the curse was, you have to think to breathe. So there you go. So that's what's going on. So patients with these kind of lesions, with these problems, go to sleep, and they die. Okay? And that's what happened to Undine's friend, or enemy, however you look at it. Awake hypoxemia and hypoventilation can occur. There's a congenital form, and we've already made some progress in that. It's the FOX2B gene that's associated with congenital, and there's an acquired. Infarcts can do it. The groups of medullary neurons that are involved with respiratory control, particularly the dorsal group. Some lesions in the nucleus tractus solitarius. The pre-Botzinger complex of the ventrolateral medulla is the basic lesion. ALS, multiple systems atrophy, even Parkinson's, which is related, and unfortunately, aging itself can lead to such disorders, especially expression of a neurokinin-1 receptor. So there's a very large biologic underpinning as well as a congenital underpinning that we're getting to do. So what do you do for this patient? We're talking about CPAP, we're talking about the servo ventilation, all these things. You wear a mask on your face. Would you want to put a mask on the face of somebody who has such erratic, uncontrolled breathing? Does that sound like a particularly good idea? What's wrong with that? Well, what if the mask slips off? And this is a patient who's coming with recurrent respiratory failure. Right? What if she forgets to put it on? What if it's just not pushing enough air down? So a general treatment that's been offered and was offered to this patient was tracheostomy with 24-hour mechanical ventilation. The only way we can guarantee that you stay alive, especially in that setting, is to do 24-hour ventilation and then figure out what else you can do. So that's exactly what this patient was offered. The patient refused, said, I don't want it. She had bipolar disorder, so a psychiatrist came and said, yes, she's competent to make that decision. She doesn't want it. So what was done? She was put on non-invasive ventilation and a ventilatory form, bi-level positive airway pressure. And here's a beautiful tracing. This is that same patient using that ventilation. So she's got REM sleep. This is the ventilator going off. It's inspiratory, expiratory, inspiratory, expiratory. So not CPAP or continuous positive pressure, but bi-level positive pressure. And here's the CO2 going up and down. Here's the thoracic and abdominal cage. Perfectly entrained to the ventilator. Saturation is now 97 to 98%. So it's beautiful, beautiful ventilation. Just shows that ventilation works. And so one key lesson here is that really think about these patients, because you could put a mask on and ventilate people even with this kind of disorder. This patient was found dead in her bed 2 weeks after the slide was taken because she's got central alveolar hypoventilation and needed the support of 24-hour assured ventilation. All right, so just to close, people talk about BO's breathing, so you're the first to really know what BO's breathing is, because I hear all sorts of things. Most people haven't even heard the term, but BO was a French physician, obviously, and these are two of his original tracings, two different patients, central apnea, erratic breathing, not periodic, totally erratic, both patients, and they each had tuberculous meningitis. So you see we're talking about, again, the central nervous system and lesions there. So BO described his breathing in tuberculous meningitis. Fortunately, we don't see a lot of tuberculous meningitis these days, although occasionally we do. But that's a whole other story, recognizing TB, which is almost harder, actually, than recognizing sleep apnea. But this is what happens when the central nervous system is lesioned. This would be a patient you could say has the same kind of central alveolar hypoventilation, maybe due to a medical cause. But this is BO's breathing, very erratic, ataxic breathing. This is more rightly called clustered breathing, clustered respiration. It's a form of erratic breathing. It's not clearly periodic. You see how some people might say, well, there's 2, central apnea 2, central apnea 2. And so you might say, well, this is looking a little bit like the Cheyne-Stokes breathing, but of course it's not. Look again at that slide of the classic waxing, waning, that beautiful diamond shape of the Cheyne-Stokes breathing. That's not this. So this is clustered with central apneas, and the most common occurrence of this kind of breathing is not so much with a central nervous system lesion like the ataxic breathing, but rather with opiates. So if you see a patient with chronic hypercapnic respiratory failure coming in and out, and particularly looking like this kind of breathing in sleep, and of course you wouldn't know it unless you look at the sleep, although it could accrue in the day as well, awake as well, think about opiates. It could also be caused by brainstem damage, strokes, increased intracranial pressure, sometimes with infarction, but most of the time when you look and you see this kind of breathing, worry about opiates. And people are addicted to opiates much more than you realize. They put on pain medications very often for all sorts of chronic pain syndromes. Okay, so here are the challenge questions, and I'll let you go over them. You can see in red what we were talking about, all the things that in non-REM sleep, with its dependent on metabolic control, that you can see, including the Cheyne-Stokes breathing, the obstructive sleep apnea, these hypoventilation syndromes, and more. Now the REM sleep, again, central apneas, you're already having central apneas, and particularly in patients with neuromuscular disorders, COPD that rely on accessory muscles. REM sleep is a terrible, terrible time, and again, severe hypoventilation and hypoxemia. So, just to summarize now, before you take your break, sleep is a state of challenged respiration and cardiovascular control. Never think that sleep is anything but that. You have to suspect it. It's a sleep-disordered breathing. It encompasses a large clinical and physiologic spectrum. I gave you a spectrum today, but I gave you a classification that as you go on, we can talk about. As I say, we could do this every day for a year, and we'll just about cover the bases, and then we'll have to start all over again. Let's take a year to do it, okay? Just get comfortable. Okay. So, These breathing disorders are common, they're severe, they're associated with major cardiovascular, cerebrovascular, metabolic disorders, both coming and going, cause and effect association. The major disorders you now need to think about every day for the rest of your clinical life are obstructive sleep apnea, central sleep apnea with Cheyne-Stokes breathing, both of which we saw, sleep-related hypoventilation disorders, that would include patients with COPD, with central hypoventilation that we just saw, with obesity hypoventilation, which is getting more and more common, and we can talk about that at another time, the neuromuscular chest wall disorders and overlaps. And please, these sleeping disorders, if you know one thing now, they're for the most part treatable if you recognize them and you think about them. All right, so you know that the lion will lie down with the lamb, but the lamb won't get much sleep. Okay, so remember Woody Allen's phrase. Thank you very much for your attention. Have a good day.
Thank you. We have time for a few questions, if anyone has any for Dr. Basner.
I have a question about the third case, patient who's obese and has HIV and for going to treat her was amenable to a longer course treatment. I'm wondering what somebody who's already hyperventilating to that point, is there, how can we kind of recondition that person on different ways if they were willing to do that? How do we talk about long term?
Well, okay, so the question you're basically talking about, I get the sense you're talking about all sleep-related breathing disorders, for example, losing weight, because her weight wasn't the problem here, is that she had a central nervous system lesion. So in a case like that, maybe there's nothing you can do about it. But the first thing you have to do is support, first of all. So again, this woman died because she didn't get the proper support, which is very common, and again, you have to recognize that, although these are not common cases necessarily. But anytime we treat, we also have to look at the underlying disorders. So for example, in obstructive sleep apnea, as I said, you have to treat the obesity, which is basically what an adult sleep apnea problem is. So while you treat and while you protect the public health from driving accident, sure, you have to lose weight and other things too. So there's always something else you can do, but the first thing is to stabilize the patient. Sir?
If sleep disorders are so common among certain populations, why isn't it screened for?
So the question is, why aren't we screening for these sleep? Well, first of all, from now on, we will, right? Everybody in this room. So I think there's a lack of this field, as it were. I don't even think it's a field. It's as basic as breathing, is undertaught, misunderstood, I think, among the medical establishment, basically, and among people. How can 80% of obstructive sleep apnea go undiagnosed? But the fact is we do screen, and how do we screen? So first of all, having a high clinical suspicion, asking the right questions for obstructive sleep apnea, thinking about the right setting. So as I say, if you have a patient that you're treating with stable heart failure, you should be thinking about the 60 or more % prevalence of sleep apnea in that patient. Then screening, if you're thinking about, do we need to come into the sleep lab and do a whole study like that? Can we do oximetry at home or portable monitoring at home that measure breathing? Absolutely, and we're getting better and better at doing that, so we can screen. There are also screening questionnaires. So for example, in this hospital, if you want to do surgery on a patient, you have to screen for obstructive sleep apnea with special questionnaires. So the anesthesiologists do that all the time. So there is actually a lot of screening going on, but it's a good point. This is so prevalent, why aren't we doing more about it, basically? We are doing a lot about it. We still have to figure out where we're at in terms of costs, consequences, what the underpinnings are, and really what the best treatments are. And what is the causes, what are the associations, where is it true and unrelated, and what's the vicious cycles. And it still needs a lot of work, but the first step is to be concerned, to be suspicious, and to go ahead and screen. Never be afraid to think you might need a sleep study, to get information, but also be at the bedside and do your own screening. It's amazing, I'll make this point, how many patients, and Dr. Atkinson can vouch for this, come to the sleep lab after being in the hospital and the doctor says, I want to know if my patient has sleep apnea. And you say, I say, how long has the patient, Dr. Atkinson is too polite to say this, but I say, how long has this patient been your patient in the hospital? 1 week? And you're asking me if the patient asphyxiates 30 times an hour? But that's what happens. So why? We're trying to work that out. Let's think a little more and screen a little more. Patients, if you go to the next heart failure lecture, you may not hear sleep talked about at all. You'll hear lots about beta blockers and ACE inhibitors and transplant. What about Cheyne-Stokes breathing? Okay. One.
Yeah, I think we have time for one quick question, and then if there's anyone else who has a question, you could probably just come up.
And by the way, come to the sleep lab and join us there. We're there at 6:30 every morning reading sleep studies. You're all welcome, not all at the same time, but to come in to join us. Was there one other question? Or? Okay.
Thank you.
Thank you.
We'll get started in 5 minutes. At the beginning, but
And then I know, but I emailed with her yesterday.
I know.
You know,
Yeah. We're so happy here. Well, we actually did not end up Phil being with we couldn't do there were no RVs to be had. But it's a beautiful part of the country.
this.
That was an extra one that was already left here. We found that.
Okay, so he's the opposite.
Yes, yeah.
He's well, but looks like he's got somebody. He had like a sympathetic. I will wear this. I don't know. I hate that like. What do you do? Do you walk around or do you use?
I wondered a little bit. I think it's safe.
Touching my hair a lot.
According to her. Who said you were touching?
Criticizing.
Okay.
So, yeah, you want to.
This is so fun. It's like you can feel like you're in the
Some people have turned it into sort of a TED Talk kind of thing.
But can you do it?
You can.
No, just wait.
Sometimes actors do that. Or in a bit like
Got it. So how many left is
Hi. It is, I think, 10:02, so we're going to get started. I have the great pleasure of introducing our next speaker, Dr. Jennifer Haith. Dr. Haith is an assistant professor in the Division of Cardiology. She's the associate director of the pulmonary hypertension program here. She's also a former co-resident of mine. And she'll be teaching you today about pulmonary vascular disease.
I decided to try to do the walk the Mehmet Oz style, but I don't know if can you hear me? Yeah. Okay. So I'm a cardiologist that does heart failure, so I take a little offense to Dr. Basner's comments about the beta blockers and the heart transplant because we send all our patients for sleep studies, especially me. And but yes, we tend to be slightly fixated on neurohormonal blockade. I'm going to talk today about a concept that seems to be very, very difficult for people to understand when they're residents, fellows, and attending in cardiology. And I'm not sure why that is, because it's actually not rocket science. It's very straightforward. How many people in here took physics? Yes, everybody, right? And you all passed. And how many people took calculus? Everybody. And all you have to do is add and subtract for this math, and it used some common sense. So I think we'll all be okay. So let me see how I do this. Okay, so the first thing to understand, I think, about all aspects of medicine that you're going to learn is that no organ is functioning by itself, right? The heart and the lungs, obviously, are very interconnected. And if you remember that as you kind of move on in your studies, you're going to realize that everything affects everything else. The kidneys affect the heart, affect the liver, affects the kidneys again, affects the lungs. So for this lecture, it's really crucial that you understand the relationship between the pulmonary circuit and the heart. So how many chambers does the heart have? You guys should know this. 4, right. So there's 2 on the right, 2 on the left. The big vessel leading out of the right side is called the pulmonary artery, right. And the big vessel out of the left ventricle going to the rest of the body is the aorta. Okay. So the pulmonary artery brings all this deoxygenated blood back to the lungs, and then hopefully will just exchange gas in a very simple way back and forth if you're healthy and normal, and then oxygenated blood comes to the left side and is pumped through the aorta out to the body. So with pulmonary vascular disease, we see problems that start to arise in this pulmonary circuit, and as a result, there's really pretty profound effects on the rest of the body, but those problems can arise for myriad reasons. It can be from the left side of the heart causing the problem. It could be a problem in the pulmonary bed itself. So we have to sort of learn to differentiate and see what's different about the different disease processes and how do we figure it out. So here's our heart that we just showed you a picture of, and here's the right side, right ventricle. This is the pulmonary artery coming out. Goes to the lungs, comes back, out the, here's the pulmonary, where's my picture? Pulmonary artery. This may have been, left ventricle out the aorta right here. Pulmonary artery here. Okay, so what are the ways that we diagnose problems with the pulmonary vasculature is to do a diagnostic test called anyone know what this is? Anyone? Swan-Ganz? I thought I heard Swan-Ganz. Swan-Ganz catheter, right? And it's not called a Swan-Ganz because it looks like a swan. It's called a Swan-Ganz because it was invented by 2 guys named Swan and Ganz. But it does kind of look like a swan a little bit if it goes into the right side, or sometimes even into the left. So here is the swan. We use this to figure out what the pressures are inside the heart and lungs. The only way to definitively know the pressures in the heart and lungs is to do a swan. We put it in, it's got a bubble it has a little bubble at the end of it that you blow up when you want to float it. You stick it into somebody's internal jugular vein here, hopefully not anywhere else. It comes down into the SVC, into the right atrium. And as you're floating it down, pressure, it's hooked up to a pressure monitor, and you can see the waves and see what the pressures are in those different chambers. So usually we record the pressure in the right atrium, the right ventricle, the pulmonary arteries, and then we open the balloon and let it float distally, and it wedges. Have you ever heard of the expression to wedge? Yes. So does anybody know what the wedge is estimating? Left atrial, you guys are good. So left atrial pressure, better than the fellows. So When you have appropriate wedge, if everything is normal in here, you're assuming what the pressure of the left atrium is, okay? So this is what a normal wedge should look like. So you go in, right? So it's the rule of sixes. So right atrial pressure should be 6. Go into the right ventricle, 12 over 6, because you have a systolic and a diastolic pressure in the ventricle. You go to the pulmonary artery, you have a step up. So instead of 24 over 6, it's 24 over 12. And then the wedge is 12. So 6, 12 over 6, 24 over 12, and 12. Those are normal hemodynamics. And so this is the picture that you see if everything is normal when you do your swan. Okay? And this is the only real way to know what the pressures are in the pulmonary bed. So what is pulmonary hypertension? Pulmonary hypertension is when you have an elevation in your pulmonary pressures. Your pulmonary artery, we just said that the pressure in your lungs should be 24 over 12, right? In your arm, it's 120 over 80. In your lungs, it's 24 over 12. The same kind of pressure, same millimeters of mercury, okay? But it's low. And when you have low pressure in your lungs, your right heart that's pumping blood to the lungs is designed to pump to a very low pressure. It's not designed to pump to high pressure. And the left side of the heart is designed to pump to high pressure. So if there's something that's causing the pressure in the lungs to get higher, your right heart is going to suffer over time. So what is pulmonary arterial hypertension? Pulmonary artery hypertension is a progressive, incurable disease of the small pulmonary arteries that's characterized by vascular cell proliferation, aberrant remodeling, and thrombosis in situ. So this is a pulmonary arterial hypertension is a disease where, for whatever reason, we'll talk about the reasons, your vessels become obliterated, they develop thrombus, they become basically not passable anymore. And it causes the pressure to go up in your lungs. So they made these guidelines in 2008 to define what pulmonary hypertension is. Not pulmonary arterial, the top is just pulmonary hypertension. So pulmonary hypertension is when your mean pulmonary artery is more than 25. So 24 over 12, the mean is going to be, 16, 18. So the mean more than 25 is pulmonary hypertension from any cause. Pulmonary arterial hypertension means that your mean pulmonary pressure is high, it's 25, more than 25, and your wedge is low. So that's an interesting concept, because in heart failure, everyone's wedge is what? High, right? Because they're filled with fluid, they're volume overloaded. So their pulmonary pressures just kind of go up together, right? The fluid comes in, the pressures all go up, you take the fluid away, the pressures come down. This disease, there's a discordance. The fluid is low, right? There's nothing wrong technically with the fluid level, but the pressure is very high. That's a different problem. If you can grasp that concept, you're like 90% of the way there, and that's very simple. Everyone get it? Any questions? Okay. So that someone decided to classify all the different kinds of pulmonary hypertension because there's a lot of different causes. So group 1 is what we call pulmonary arterial hypertension. That's true pulmonary hypertension in the sense of people who have connective tissue diseases, lupus, scleroderma, HIV, idiopathic, familial. We can't really explain it, but they have just regular, good old-fashioned pulmonary hypertension. Group 2 is really not technically PAH, it's just PH, and it's PH from left heart disease. So that's anybody who has high pulmonary pressures from heart disease. That could be heart failure, that could be valve disease, it could be you have wide open mitral regurgitation and your lungs are flooded. It's all secondary to the heart. Group 3 is more about what we've been talking, you guys were hearing about before. So people who have chronic lung disease, so maybe their lung tissue is obliterated by interstitial lung disease, they have COPD, emphysema, they could also have sleep apnea, all of these other causes that cause the lung tissue to be destroyed, and that raises the pressure in the lung. Group 4 is chronic thromboembolic PH. So that's people who have multiple blood clots over time in their lungs that causes the pressure in the lungs to go up. Recurrent, repeated pulmonary ampullae. And group 5 is sort of we don't really know how to classify them otherwise, sarcoid, some people who have it from cancers, things like that. So here's the same guidelines I just told you, but a little bit more drawn out. So group 1, idiopathic, heritable, drug and toxin induced. So that's like, you guys ever hear of fen-phen? That's so long ago, but it was a weight loss drug that caused pulmonary hypertension. pH of the newborn, you're not talking about. Connective tissue disease, HIV, congenital heart disease falls into this classification because those patients, because they're born with their diseases, behave much more like a group 1 than like a group 2. This is its own disease you probably already know about. PH owing to left heart disease. So systolic heart failure, diastolic heart failure, and valvular disease. Do you guys remember the difference between systolic and diastolic heart failure? You know what that means? So systolic heart failure, your ejection fraction is low. Diastolic dysfunction, by itself, your ejection fraction is normal, right? But your heart is very stiff. This is a huge percentage of the pulmonary hypertension that I see in the office. People have a high estimated pulmonary pressure by echo. They get referred for a pH evaluation. Just turns out that they're like, little old ladies who've had hypertension for 40 years. Their hearts are really stiff. They don't relax well. And they end up with a very high wedge pressure and high pulmonary pressures. And all they need really is diuretics and blood pressure control. And then valvular disease, mitral stenosis, especially the mitral valve. pH owing to lung diseases and or hypoxemia, which causes hypoxic vasoconstriction, which becomes irreversible over time. So COPD, ILD, sleep disordered breathing. This is important because this classification of pulmonary hypertension doesn't tend to respond well to the medication we have. So they're a little bit in a different grouping and harder to treat. CTEPH, chronic thromboembolic pH. So we just, recurrent PEs, and I'll show you at the end, we actually have a surgeon here who can do a surgery to remove these clots. And it's actually the only kind of pulmonary hypertension that's totally reversible. And then this is the unclear. Okay, so classification by location. I'm trying to bang it in your head. So people with WHO group 1, right, their problem is something that's wrong with the vessels in the lungs. So this is the location of that disease. WHO group 2, the problem is in the left heart. That's for the focus. Group 3, hypoxemia in the bronchus and the alveoli. And group 4 sort of falls into this category because you end up with blood clots in the pulmonary arteries. Okay, so in order to really understand the physiology of this, you kind of have to at least master the basics of the numbers of the SWAN and the numbers of the hemodynamics. Okay, so we said already that pulmonary hypertension is a mean pulmonary pressure of greater than 25. Okay, this is literally as hard as it gets, and it's not that hard. Change in pressure is flow times resistance. Okay, this is a calculation to tell you what the mean pulmonary artery pressure is. So if the mean MPA is the mean PA pressure, Q is the right-sided cardiac output, PVR is the resistance in the lung, and PPV is the pulmonary venous pressure, also known as the wedge. So usually the cause of an elevated PA pressure is because the PVR is elevated. This is in the traditional patients with pulmonary hypertension, arterial hypertension. So what is the PVR? The PVR is the resistance in the lungs. So the resistance is going to be high if there's something wrong with the vessels of the lungs, right? You're not going to have good flow of blood through the lungs. It's going to be like stenotic almost. So how do we calculate the PVR? PVR is a very easy calculation when you've had a cath. So you take the mean PA pressure, which is literally printed out for you, okay? You take the wedge, which is also printed out for you. You subtract them, okay? No rocket science. And you divide it by the cardiac output, which is also printed out for you, okay? So a high PVR, we see this in occlusive vasculopathy, group 1. We see this when we have a decreased area of the pulmonary bed, like in PE or ILD, group 3 and 4, and we see it in hypoxic vasoconstriction, group 3. When is pulmonary pressure high because of high flow? So when would somebody have too much flow going through their pulmonary bed that might make them sick? Right, congenital heart disease, so lots of continuous left to right shunt over time. Think about someone who had an unrepaired VSD, right? They have a big hole in the middle of their heart. Their whole life, they've been having blood going from the left to the right with every beat of the heart. And over time, the pressure in the lungs is going to go up because it's not supposed to see such high pressure. And then increased pulmonary venous pressure. So this is what we talked about already. This is group 2. Okay, so what happens next? So we've established that the pulmonary pressures are high. So this is the left ventricle, this is the left atrium, this is the right atrium and the right ventricle by echo. What's wrong with this picture? What? What's too small? The left, right? The left is supposed to be much bigger than this, and the right is way too big. So this side is very, very dilated, and it's pushing on the left, okay? You see this right here? This is what we call a D-shaped septum. So this high pressure on the right is pushing onto the left, and it actually inhibits the ability of the left side of the heart to contract well. So the RV dilates and the cardiac output drops. So not only is the pressure high in your lungs, so blood is having trouble getting through there, but now your output is low too, right? So you're not pumping well to that area. So it's like a double whammy. Okay, so this is a picture of WHO group 1 pH. So it's a proliferative vasculopathy. You get vasoconstriction, cell proliferation, fibrosis, and thrombosis. And so this is sort of the picture we see. And the pathologic changes that happen. So initially, you have these risk factors, or you might have some genetic susceptibility. And then you get vascular injury with, intimal proliferation, smooth muscle hypertrophy. This is all the stuff that scientists like and is boring to the clinical people. But this is basically like the vessels are getting obliterated and destroyed. And this is disease progression, and you get to a point where you have this advanced vascular lesion that you can't reverse. It's called a plexiform lesion. So here's the clinical course of these people. So your PVR increases, so the resistance is going up. Your pulmonary pressures are going up. Your BNP, you guys know what BNP is? It's a little marker for how much your heart's stretched out and how much fluid there is goes up. Your heart association class is going up, and your cardiac output is going down, and you're dead. So it's a multi-hit hypothesis, right? You might have a genetic component, some environmental factors. This is for pulmonary arterial hypertension. So how do people with PH do? How do people who have, let's say, lupus, who have terrible pulmonary hypertension and right heart failure as a result, how do they live long? Do they die quickly? What happens? So this is an NIH registry that's old. Okay, so this is before a lot of the drugs we have now, but by a half a year, they were almost at 60%. Right? That's bad. Okay, and by, 5 years, 30% were still alive. So etiology of pH mattered a lot. This is also a little old, 2004, but the congenitals lived the longest. Why do you think that is? Anyone? Oh, I see someone back there whispering. What? They can compensate. They've had it their whole life, right? Presumably, if it's congenital, right? So their hearts are tough and thick. They've been dealing over time, right? So they don't have the same problems as someone who develops it later in life. This is idiopathic PH, or PAH, like we were talking about. Connective tissue, this is idiopathic, right? We don't know why they have it. Portopulmonary is up here. We haven't really mentioned that, but that's people who have really bad livers, who have very high output liver failure, and they can have pulmonary hypertension, but we don't really know why. It's that whole, you guys still talk about the bad humors? Does that ever come out in any of your lectures? The bad, we don't know. We don't know why the liver, what's coming out of the liver, but it's making people have PH. And often they reverse when they get a liver transplant. Connective tissue diseases don't do so well, and HIV did the worst. And it doesn't matter if you're on therapy for HIV, it doesn't matter if your viral load's undetectable and your CD4 is a gazillion, you still do badly and get it. So what do we want to know in the history? We want to know about dyspnea on exertion, fatigue. Syncope is a very poor predictive prognostic factor, because that means if you're syncopizing from your pH, you're pretty far along and very sick. Chest pain, dizziness, swelling in the legs from right heart failure, cough, hemoptysis, hoarseness, anorexia, right upper quadrant discomfort. Clinical signs, RVH, tricuspid regurg, RV failure, third heart sound. Have you guys done any clinical? Have you, listened to anybody's heart? Yeah, okay. Elevated neck veins, JVD, so different. Last time I was in here was 15 years ago, which is so depressing. But I had PTSD coming in here, I think, because I was oh God, it's like torture. But we had, the only difference is you guys all have computers, but you can see what everyone's reading in front of you. So you can't really, be on your computer. You have to actually sort of be paying attention. And then hepatomegaly, edema, EKG screening. Okay, so history of smoking, alcohol, recreational drug use. So there is some evidence that crystal meth, so nobody used any crystal meth here, crystal meth can cause pulmonary hypertension, particularly people exposed to the making of crystal meth, which we all learned in that TV show is very bad for you. But it causes really bad pulmonary hypertension. In fact, one of my colleagues who treats children saw, this is actually really sad, a family of kids who all had PH because their father was making like crystal meth in their house and they were exposed to the smoke. Cyanosis as a child is for congenital heart disease, joint or muscle pain for connective tissue disease, Raynaud's syndrome for connective tissue, family history, previous DVT or PE, use of appetite suppressant drugs is less relevant now, high altitude living. Okay, and then you guys learned about New York Heart Association heart failure, class 1, 2, 3, 4. 1 is no symptoms, 2 is slight limitation with moderate activity, class 3 is marked limitation, and class 4 is short of breath at rest. It's the same for PH. So what do we see on the chest x-ray? So the pulmonary arteries are usually quite enlarged, right, because they dilate over time because the pressure in them is so high. And right here, we see a loss of what's called the retrosternal space, right, because the right ventricle is here and it's gotten really big and it's sort of closing in there. So you should have a bigger space between your sternum and your heart right there. Okay, EKGs. Have you guys read an EKG? Have any idea what you're looking at here? Okay. So this is the P wave, QRS. You can see here that this patient is in sinus rhythm, but their atria are big, right, because they probably have right heart failure. Usually we see right atrium is big. They have a right bundle branch block because their right side of their heart is bigger and there's a conduction delay there. And so that's not normal. Okay, and here's another picture of the echo. I mean, obviously I'm finding pictures that are very profound, but this is like a very dramatic picture of how dilated the right atrium and the right ventricle are and how small the left side is, and how you can understand why someone with this degree of right heart dysfunction and pulmonary hypertension could actually end up with left heart failure and low cardiac output because, I mean, how can this heart pump? And this is what we call ventricular interdependence. So in the presence of PH, ventricular interdependence exists. Right ventricle volume and pressure overload will shift the interventricular septum over, and this limits filling and output. You need an optimal preload to minimize RV volume but maximize LV filling. Okay, so confirmatory diagnosis in PH. We said this, right heart cath is the gold standard. So what do we do in the cath lab when we decide to cath these people? So they come into the cath lab and we do a cath, and let's say we find some information that their pulmonary pressures are very high. We want to know what kind of treatment they're eligible for. Do they respond to a vasodilator challenge? Do they not respond? I think this is the concept that seems to throw people for the biggest loop when I'm trying to explain pulmonary hypertension diagnosis in the cath lab, because it's a little counterintuitive, but just listen and you'll see why. So if someone responds, so that we're going to talk now mainly about real arterial hypertension. So you go in, your pulmonary pressures are high, and your wedge is low. Okay, so you don't have a lot of fluid in there, and you want to see if they're a responder to a vasodilator. If someone does respond to a vasodilator, that actually carries a better prognosis. And what we do is we treat them with a calcium channel blocker. Very high dose. So we would start low, but try to get up to like 360 a day, 480, even 520. Very high doses of calcium channel blockers. They live longer. They have a longer time to progression. They may eventually not respond anymore. You have to repeat the caths and then determine if they need to have real sort of more sophisticated pulmonary hypertension medication. But for them, it's good if they respond because these are pretty non-toxic medication, a calcium channel blocker. So what we do is we infuse a short-acting vasodilator like Flolan. Have you heard of Flolan anywhere? Nitric oxide or adenosine. And only if your wedge is low, because if you think about this, you're going to give them a vasodilator, right? So they're all constricted down. You give them a vasodilator, and let's say they respond. You're opening up all those blood vessels. If they had a very high wedge and had heart failure and you did that to them, what would you do? You would drown them, right? You would just flood their left heart with more volume. So you don't want to do that if their wedge is high. You only want to do it if their wedge is low. So we look for a decrease in the mean pulmonary pressure of less than 10 millimeters to less than 40. And only about 7 to 10% of people will be responsive to this challenge, but they have a favorable prognosis. And these are, as you can see, long-term calcium channel blocker responders, and this is failure, and you can see the significant difference in their life expectancy. Okay, and the reason that I find that it's counterintuitive is because if you don't respond to the vasodilator acutely in the cath lab, you then move to a true pulmonary vasodilator in the medication setting. Does that make sense? It's a little weird. You do respond in the cath lab, you get a calcium channel blocker. You don't respond in the cath lab, you get a real pulmonary vasodilator. Okay? You guys are all nodding. Everybody I explained it to is like, wait, when do you get a medicine? Okay, conventional therapy. So oxygen actually is one of the few things that actually prolongs life, especially in the WHO group 3 patients. So you want to target their O2 sats to more than 90. Diuretics have been traditionally used in pulmonary hypertension. About 50 to 70% of patients in recent randomized clinical trials were on diuretics already. They are symptomatic relief in patients with right heart failure, and they're used by most doctors and patients who have right heart failure. Anticoagulation. Again, about 70% of patients in recent randomized trials were on anticoagulants. It's recommended to be used if no contraindications exist because there's a concern for the development of pulmonary emboli in patients with pulmonary hypertension. They have a higher risk of PE. And then DIG, so used in about 25 to 50% of patients in recent trials. It's really on the physician's judgment. Sometimes it's helpful. There's a little bit of a positive inotrope for the right heart. Sometimes it's helpful in controlling your heart rate in patients who may have some arrhythmias related to their right heart failure. So the interesting thing about pulmonary hypertension is the drug design is kind of fascinating to see how all the different drugs were designed and why and how. So because it's like they target the very specific pathways that we understand. So back in the 80s, we had like nothing. So people were like dropping off like flies, DIG, diuretics, anticoagulants, and calcium channel blockers. In 1976, this guy discovered, Sir John Vane discovered prostaglandin. So that was a big discovery, but it doesn't get put to use until later. So here in the 90s, Flolan comes around, which is an IV prostanoid. And this was huge because all these patients who had severe PH were given Flolan, which was an IV pulmonary vasodilator, and it helped their pulmonary pressures came down. It really prolonged their survival, allowed them to get to lung transplant. So that was a huge development. And they demonstrated that it really extended survival. And then since about 2000, there's been this like rash of drugs that have come out that target different areas in the pathway of pulmonary hypertension. I don't know if you've ever heard of any of these drugs. You've probably heard of sildenafil because it's also Viagra. So they discovered that Viagra was a potent vasodilator, as we know, and that if used in a slightly different dose than for erectile dysfunction, it was very beneficial in vasodilating the pulmonary bed. So this is this little nice pictorial of the disease, the different pathways that were targeted for the different drugs. So the endothelin pathway. So we know that in patients with pulmonary hypertension that there's too much vasoconstriction and too much proliferation. So they developed these endothelin receptor blockers, so to try to stop this process. So these drugs are bosentan, also known as Tracleer, ambrisentan, also known as Letairis, macitentan. So you've probably heard of some, I don't know, maybe you've heard of some of these drugs. There was recently, they were in the New England Journal, macitentan came out, there was an article in the New England Journal. This is the nitric oxide pathway, okay? So this is a drug, this is a pathway where nitric oxide is released, but in patients with pulmonary hypertension, you want to enhance their vasodilation and enhance antiproliferation. So you want to have nitric oxide sitting around more. So that's the Viagras of the world, bisphosphodiesterase type 5 inhibitors. So Cialis, sildenafil, so these are all drugs that were designed for this pathway. Prostacyclin, so this is the Flolan pathway. This is a very important pathway in vasoconstriction in patients with pulmonary hypertension. So prostacyclin derivatives enhance cyclic AMP and promote vasodilation. Flolan, Remodulin, Ventave, the inhaled forms of those drugs, and now they even have an oral form of those drugs. So this is, again, for group 1 patients, this treatment. Not for group 2, not for group 3, and some do treat group 4. Group 4 can behave a little bit like group 1. So this drug, this is the prostanoid, so Flolan, Remodulin, very effective. What are some of the complications? So you have to be, initially you had to have mainly delivered through an IV. So you have to have an indwelling Groshong or catheter of some kind, PICC line, to deliver it continuously all the time. People can get a lot of strange side effects from the vasodilatory properties, so they can get jaw pain, they can get flushing, they can have diarrhea, anything that you would get from a lot of vasodilatation. And the one thing about Flolan and these drugs, they realized they have very, very short half-life. So Flolan needed to be kept on ice, so ice packs on it, and if your line broke or something fell out, you really had to get to an emergency room within an hour, hopefully, because you could have rebound pulmonary hypertension with the drug being turned off and have like a severe pH crisis. That's been a little bit attenuated. Like Remodulin has a slightly longer half-life and doesn't need to be kept on ice. It doesn't need to be thermostable. And then they have some inhaled forms and oral forms, which probably aren't as effective, but obviously don't need that. Okay, so PD5s, Tadalafil, Cialis, Sildenafil, Revatio, Viagra. This is the easiest to prescribe, and you'll see the most patients taking, in the community having been prescribed this by doctors who think they have pH. So they'll get, Revatio, it's 20 milligrams 3 times a day. It's sort of the easiest prescription process, I would say. It does have some drug interactions. Again, people mainly complain that they feel flushed when they take it. Their cheeks get all red and hot. And then the ERAs, so Bosentan was the first one. Again, it's a twice-a-day pill, but it had a significant liver toxicity associated with it. It had some drug interactions, very teratogenic. Can't be pregnant on it. Actually, you can be pregnant on Flolan, so it is one of the drugs we use if we do come across a pregnant woman with PH, although having a pregnant woman with PH is its own very scary, complicated thing because they have a very high risk of dying. So we try to prevent women from getting pregnant if they have true pulmonary hypertension. Letairis came along afterwards. It has no liver toxicity that we know of, and so the black box warning was removed. And the newest hit on the block is Macitentan, which is another ERA, which is very effective. We sort of talked about this. This is the prostacyclin pathway of Sildenafil, Viagra. This is epoprostenol, so this is Flolan, and you can see that in the epoprostenol group, I think the difference really appears at 4 weeks. This was done by Robin Barst, who was one of the first PH doctors here back in the 90s. She did this study, it was in the New England Journal, using Flolan, and you can see that there's a significant improvement in patients on Flolan. It's not a huge study, but they had a significant improvement in their survival. And long-term outcome in patients with IPH with epoprostenol, so you can see IV epoprostenol versus historical controls. There's a statistically significant survival benefit observed in the ERAs we talked about, and the PD5s. Sorry, before it was the prostacyclin. This is the PD5s. Nose bleeding, headaches, diarrhea, flushing, visual changes. And I think you guys know this, but can't be used with nitrates, so no, because it can cause heart ischemia for coronary patients. Okay, so the effect of Sildenafil. So this was the study that came out also in the New England Journal in 2005, where they tested different doses of Sildenafil. You can see that the 20 milligram, 40 milligram are pretty close together. The 80 had a statistically significant benefit, but they felt that the real benefit was between nothing and 20. So FDA only approved 20 milligrams 3 times a day, although we do see people go up to 83 times a day. It's just sometimes it's hard to get insurance to approve that. This is Tadalafil on 6-minute walk distance. I mean, the thing is, you have to remember for these people, we're talking about a difference of being able to walk 10 meters and 30 meters. So it seems like not a huge improvement, but for them, it's the difference between being able to walk to the bathroom before they get short of breath or walk maybe across their whole house and out the door to get the newspaper, which is a big difference. So briefly want to talk about WHO Group 2 because this is what I see a lot of as a cardiologist, and if any of you in the group are going to become cardiologists, you'll see a lot of this too. So these people have an elevated wedge. It's really pulmonary venous hypertension. If the other stuff we were talking about was pulmonary arterial hypertension, this is pulmonary venous hypertension. And the reason is that these pulmonary veins that bring oxygenated blood back to the left side of the heart are filled with fluid, and that pressure backs up into the pulmonary bed. So this is the sort of hemodynamic little grid of groups 1, 3, and 4 versus group 2, and then there's always mixed, right? So you get some people who have some diastolic heart failure, and they have sleep apnea, and they have lupus, so they may have a little bit of a mixture of everything. So in group 1, we said the PA pressure is high, the mean PA is high, the wedge is low, and the PVR, which we talked about before, does anybody remember? Mean PA minus the wedge, so 25 minus 15, divided by the cardiac output. So this would be 10, and let's say you have a normal cardiac output of 5. Your PVR, let's say you have 25 minus 15 is 10, and let's say your cardiac output is 2, your PVR is going to be 5. That makes sense? Pulmonary venous hypertension, your mean PA may be 25, but let's say your wedge is 20. So then the difference between your mean PA and your wedge is only 5, right? So it's 5 divided by the cardiac output. Let's say it's 2.5, so that would be 2. So it's a low PVR. Your resistance is low when it's reversible from fluid. Your resistance is high when it's irreversible from occlusion and obliteration of the vessels in your lungs. And then mixed can have a mixed picture. So this is, again, understanding the hemodynamics. So normal, they did sort of the rule of 5s and 6s, but it's RA 5, RV 20 over 5, PA 20 over 8, LA is 6, so the wedge is 6 here. In this patient, the LV is dilated and big, the wedge pressure is up to 25, the PA pressure is up to 45 over 25, right? In this patient, the LV is dilated also, but why is the PA pressure 80 over 30? It's not 45 over 25. It's not high, but it's really high. This is a little disproportionate, right? This is sometimes we see in chronic heart failure, or if someone has a secondary cause or a mixed cause. But even in chronic heart failure, if you've been walking around with a wedge of 30 for like years, not well treated, you can have some what appears to be a fixed component of pulmonary hypertension. And in those patients, the PVR is actually high, even after we give them a vasodilator test and try to bring their wedge down. So what we do is we often treat them with milrinone or inotropic vasodilator to help their heart failure, and that maybe 6 weeks, and then we repeat the cath to see if their PVRs come down, because sometimes they do revert, they come back. Their pressures come down, but they're like a little stunned and need a little while to come back. Have you guys ever heard of an LVAD? Okay. An LVAD is did you guys have a lecture on it? Yeah? Okay, so an LVAD is a pump that goes into the left ventricle, sucks blood out of the left ventricle and sticks it back into the aorta. Okay, it bypasses the failing left heart. It's pretty cool. It's probably the future of heart failure, but it's not streamlined enough yet, so it's still a very arduous thing to have along with you. Jarvik invented one that the drive line comes out of behind your ear, so that's a lot different than having a cord coming out of your belly. But this is an example of an LVAD, right? So here's the cannula sticking into the left ventricle. It's sucking blood out and sticking it into the aorta. This is what literally comes out of your belly as a drive line, right? You plug it into batteries. This is the Jarvik I was just telling you about. It comes out behind your ear. So in patients who have chronic heart failure, who may even have elevated resistance, more than you would expect in just heart failure, LVADs have been shown to reduce the pulmonary resistance over time. So they do a right heart cath on someone before they get an LVAD, and their PVR is 6, and it's too high. They're waiting for transplant, but they don't want to activate them until their resistance comes down. And then we find that if 6 months or a year, we recheck the right heart cath, the pressures are much lower after the LVAD has been unloading them for so long that their pulmonary pressures have a chance to come down and simmer down. That is not something that you would see with primary pulmonary hypertension. pulmonary arterial hypertension because it's more fixed disease. The other thing, and I was going to tell you guys something about the Group 4 is, this is kind of an interesting group of patients with PH because we're lucky enough to have a surgeon here, I said, Matt Paquetta, who does a procedure called a pulmonary thromboendarterectomy. So in that case, he removes old clot and old sort of fibrous much that's on the side of the pulmonary vessels and that's literally occluding the vessels because of chronic PEs over time. And he actually carves it away from the side of the vessel. I'll show you a picture. And takes it out. And literally people go into the OR with a pulmonary pressure of 80/40 with a mean of 50, and they come out with a pulmonary pressure of 24/6 with a mean of 12. It's really, it's pretty unbelievable. It's different from an embolectomy. An embolectomy, if someone has an acute pulmonary embolism, they can go in and remove that clot. This is more of like what you see in the carotid artery when people get endarterectomies. They actually are like peeling away this stuff on the side of the vessel. So this is literally pictures of what he takes out. So this is a little more proximal disease. It's literally from the pulmonary vessels, but this you can see how it literally goes all the way out into these little vessels. Sometimes it even has little pieces going all the way out. And you can understand when you see this, why when all of this gunk is taken out, that their pressures go back to normal afterwards. And you can also see that this doesn't look like clot, right? This looks like chronically changed, fibrotic, like almost like plaque, you know? And that's what happens over time to these people. Okay, so this is a little simple right heart cath data review, because I know you guys are up for it, because you can do algebra. Okay? Is this high or low for the right atrium? High. High or low? Okay. High or low? Okay, what's this called? What's this number? Mean PA pressure. Good. You guys are good. You're better than the fellows. Okay, what is this? Wedge. It's low, right? What's this minus this? 32. The cardiac output's 3, so 32/3 is 10.6. Is this a normal PVR? No, it's very high. This is the right heart cath data of someone who has pulmonary arterial hypertension, okay? What I was going to tell you before is a normal PVR is really like 2 or 3, right? In patients who are being evaluated for heart transplant, there's different institutions have different criteria, but usually people say somewhere below 4 or below 3 is what you have to have in order to get a heart transplant. Why? If you have this crappy heart that's in your body and can barely pump, right, and your resistance is 4 or 5, it's high, what's the problem? Why can't you just get a heart? Why not give someone a new heart?
You're like setting up the heart for, like, you're not setting it up for success.
Yeah, right. You're setting the new heart up for failure. So even though it's a new heart and it's a snappy new heart, right, it's not used to a PVR of 5, right? Assuming you got it from a young, healthy, like motorcycle victim or some horrible tragedy that you you never want to take donor call because the stuff you hear is really pretty shocking. So anyway, you've got some like horrible dead person who's got like a beautiful new heart, and you'd think, okay, they can handle it, but they can't. And their right heart will fail if you stick it in there with a PVR of 5. Okay, so we want their PVR to be lower, and we do everything we can to get their PVR where we need it. Okay, so this is PAH. This is something you would see in groups 1, 3, or 4. You see a low wedge pressure, high PVR. This might be a lupus, HIV, COPD, ILD, or CPAP. Okay, here's patient number 2. High or low? High or low? High or low? High or low? High. What's 39 minus 29? Ah. Cardiac output is high or low here? Low. What's normal cardiac output? 5 or 6, right? Okay. So 10 divided by 3 is, okay, high or low? Or normal? Good. This is group 2 pH, traditional group 2. This is someone with a high wedge, a low PVR, CHF or valve disease. Oh, that's it. Okay, lay it on me. I feel like, tell me if you don't get it, because it's not hard. You just have to, like, pay attention, which is hard. Okay, I have a question, anyone?
If you have pulmonary hypertension secondary to like ARDS,
Okay. Yes. I mean, you can see pulmonary pressures go up in the setting of an acute illness, like PE. I guess ARDS will defer to Amy because I'm not a lung doctor. But yes, I mean, you can see someone's pressures go up in that setting, and then if they've recovered and resolved, they'll go away.
Can you go over again? So you said that in the cath lab, if you're responsive to the vasodilators, you give calcium channel blocker.
Yeah.
But if you're not, then you give them option vasodilators.
So if you respond in the cath lab to a vasodilator, you're a candidate for a calcium channel blocker. If you don't respond in the cath lab to a vasodilator, you're a candidate for a vasodilator.
So they give a vasodilator to see if it works in the long run.
Right, so if it doesn't work, right, so people who don't respond in the cath lab, that doesn't mean you're not going to respond over time to a real drug. So those people are candidates. Usually we'll start with sildenafil, then we'll add an ERA, then we'll add an inhaled, and then when they get far enough, we put them on IV. But, right, failure to respond in the cath lab does not mean you're going to fail to respond over time to the drugs themselves. And you need to demonstrate that to insurance companies or they won't approve drugs. Yeah, LVAD is what?
treatment for group 2 patients,
Yes.
but in the PPR you said no, and that's
Well, so in some patients who have heart failure, who are being evaluated for transplant and VAD, they can have a high PVR. And in those patients, it's usually because, so let's say your mean PA pressure is 30, right? Let's say it's high because you have heart failure. And let's say your wedge is 22. So your difference is 10. But your output is really low. Like let's say your cardiac output's only 2.5 even. Your PVR is 5. So even though that patient probably doesn't have PAH, they have some component of a high PVR, probably because of chronic low flow heart failure, high wedge. It can cause some kind of higher resistance for some people that it reverses. And it reverses if you help their output and lower their wedge over time. So sometimes we try with like milrinone, and we give them milrinone and their output improves. And sometimes it's just only making the output better, because that's gonna lower your PVR, right? It's a division problem. So if it's still 10, but you've made your output 4 because you're on milrinone and it's helping whipping your heart to pump, then your PVR is going to be 2. So you're like, okay, that person, we know that in the right scenario with a better heart, this person's PVR is actually low. But in some patients, the PVR is higher, and it's not clear if it's because they have sleep apnea concomitantly, is it because they've had long-standing heart failure. But what we have shown is in those patients, if you put in an LVAD, and the LVAD is continuously unloading them, so they don't have a wedge of 30, they have a wedge of 10 or 8, that they actually their PVR comes down. And then they're eligible for transplant.
I was just curious, how is that surgery done, Dr. Jones? The surgery?
Right. So it requires, so it's open heart surgery, and it's not just being on bypass, it requires something called circulatory arrest. So he actually has to drain the heart and lungs of all blood. So patients are cooled, and they're cooled in 20-minute intervals. So he'll completely cool, put the head on ice, cool the core body temperature down to really lower the metabolic rate. The lungs are cleared of blood, right? You're oxygenating them on a bypass machine, so they don't need to be oxygenated in their lungs. And then he does 20 minutes. He has 20 minutes to get in there, before you're at risk of having some brain damage. Then they warm them up. Then they cool them again. And then he does the other side, if it's on both sides. And the actual technical part of how he does it, I'd have to ask him. He uses probably a scalpel, some tweezers. I don't know. I don't know. Do you guys know?
actually, I think there's
Like a roto-rooter?
Yeah, it's one of these, basically,
Yeah.
or I think it's a dissector. But this is an interesting operation because for years, the only place where you could go and get reliable results was UCSD because they had this amazing PE program. And their mortality rates were somewhere around 3 to 5%, which is still pretty high, right? If you did it anywhere else in the country, your mortality rate was up around 20%. So if you could afford it, you would fly to San Diego to have your operation. But the equipment is improved, and this is a very specialized center for cardiac surgery and lung surgery too. And so if you have a lot of volume, your surgeons get pretty good at this. And if your equipment's better and your surgeon's doing a ton of really complicated surgery, you have a much lower mortality rate.
And our surgeon went and trained in San Diego.
Yes.
And I have like pictures from the last 2 days where he literally did 2 patients 2 days in a row. One was 72, one was 82. I have the images that look just like that junk up there, and their pulmonary pressures on the screen are like literally 24/12 with a mean of 18. The neck, literally like the moment they come out of the OR. It's crazy. And they then can breathe, like they're off oxygen, they're walking around. It's really unbelievable. But there's not that many patients that have chronic thromboembolic pulmonary hypertension. So, and you also want to make sure, that they don't have an underlying malignancy. Like, why are they suddenly clotting up their lungs? They probably have a hypercoagulable disorder, but, you want to make sure there's nothing else going on.
Thank you so much. This is terrific.
Do you think they understand anything?
Yeah, I think